introduction, because we don't know Bogdan. He will be our guest also in this panel, so in this discussion panel. Bogdan Pană is a neurologist. He specialized in headache and neuromodulation. He specialized in Bologna. He started a master's degree in headache science in Rome. But most importantly, in 2020, he was nominated Doctor of the Year in the section Romanian Healthcare Awards, because he was the first who was implementing a neuromodulation program with transcutaneous trigeminal nerve stimulation for migraine patients. So we will discuss about TMS. And there is a question, a big question here. Does it deliver what it promised? There are enough contestants of this method. And I think for the interest of the public who is specialized, we are talking here about psychologists, and also because we have future medics, we have also interns in medicine. So it is important to clear this issue, to see if it is true that TMS is good enough to solve some issues, and what are those issues. And we will discuss also about about how this method can be developed in the future, how the futures look like with TMS. And we will start with Bogdan, because Bogdan has a specific view on this topic. He works with TMS from some time now. He has clinical experience. So we will have two different visions, one from Tuomas, which is a researcher in this field, and one from Bogdan, who is a clinician. So let's start with Bogdan. Bogdan, you have the floor.
Thank you very much for your kind introduction. I want to open the presentation, and I hope that I will manage to make the share screen work. Does it work? The share screen?
No.
Okay. Then I'll ask for help from one of my colleagues. If not, share like this.
Now it's working.
Good.
Yeah.
I'm glad that I managed myself.
So
okay, I'll make a full screen.
What I have to state, because I forgot this, this panel of discussion is presented by Emerald. They helped us a lot in this endeavor, in this conference, so you should know that. And we are grateful for that.
Thank you too.
No one, Bogdan?
It's our pleasure to support you in this endeavor. Sorry. So, as Florin said, I'm Bogdan Pană. I'm a neurologist at Emerald Medical Center. And my presentation for today, it will be about TMS. Does it deliver what it promises? TMS, I don't know exactly who is watching this. TMS stands for transcranial magnetic stimulation. I don't know how familiar are you all with this. Have you heard of it? This is how a TMS machine looks like. This is the TMS machine. Do you see also my pointer, or?
Yes, we are seeing your pointer.
Okay. This is a TMS machine, and this is the coil that is connected to TMS machine. And with this machine, we can modulate almost any brain region, because we can put this coil almost anywhere on the skull. And this particular type of TMS can penetrate 2 or 3 centimeters deep into the brain, and we can access different areas of the brain. And that's why this therapy is so versatile, because we can do a lot of things with it. This TMS is a form of neuromodulation. I'm for the last 5 years fond of neuromodulation. Neuromodulation is the alteration of the nerve activity through targeted delivery of a stimulus, such as electrical stimulation or chemical agents, to a specific neurological site in the body. The modern era of neuromodulation started in the 60s with deep brain stimulation. Now is a well-established form of therapy for Parkinson's and essential tremor. Nowadays, neuromodulation, both invasive or non-invasive, is indicated in movement disorders, epilepsy, medical rehabilitation, or psychiatry. This is how it works. It's a magnetic flux that induces an electric field in the brain, and is non-invasive. It's very easy to do it. Also as a practitioner, but also as a patient, it's very easy to do it. We can do it as a single pulse TMS with a single zap. We can do this for both diagnosis of some neurological disorders like ILS, or we can do it, the single pulse TMS, for finding the motor threshold. This is important because all the treatment is individualized based on this every person's individual motor threshold. We can do it, and this is our subject for today, repetitive transcranial magnetic stimulation. This is for treatment. We can do it in a low frequency, as is pictured here, with 1 Hertz, 1 pulse per second, or high frequency, more than 10 Hertz per second, or more than 5, it depends, up to 100, we can do it. We say that if we do it with less than 1 Hertz, we can inhibit some regions of the brain. And if we do it with more than 5 or 10 Hertz per 10 beat stimulus per second, 10 Hertz, we can excitate some regions of the brain. This is how the coils look like. They can be a round or a figure-of-8 coil with advantages and disadvantages for both. With the round coil, we can access some bigger areas of the brain. With a figure-of-8 coil, we can be more targeted. As I said, advantages and disadvantages for both. 5 years ago, I was wondering what I can bring in our clinic for our patients, for both diagnosis and treatment, and I saw this transcranial magnetic stimulation. And I've searched the internet, and there were indications for Alzheimer's, Parkinson's, neuropathic pain, epilepsy, tinnitus. Tinnitus is very hard to treat. It's very bothering. Multiple sclerosis. I'm a neurologist, and I saw all this. They were looking. It was very interesting to see that it can have indication in all this. Depression, schizophrenia, autism, obsessive compulsive disorder, PTSD, addiction, Tourette's, including there were some studies with electromagnetic hypersensitivity. As you can see, this is a bit too much. It looks like a scam almost, because this is it cannot be something that can cure all this. And this is not our promise. We cannot promise that we can treat all this. And you saw that my presentation for today, it's TMS, does it deliver what it promises? So we must define what it promises. It promises mostly what's in the guidelines. We have some guidelines. First is from 2014. And in 2020, we had an update. These are the guidelines for, I don't know if you see all of this. Okay. These are the guidelines for the last guideline. You can see that we have a lot of pathologies here. Level A efficacy means definite effect. We have level A for neuropathic pain. We know that we have definite analgesic effect. We have level A for motor stroke in recovery of post-acute stage. We have level A for depression. we know for sure that it works very good in depression, different protocols. We have also level B and level C indications for other diseases. These were the guidelines in 2014. As you can see, there are a lot of diseases here, more than in 2020, and a lot of no recommendation for a lot of disease. No recommendation doesn't mean that it doesn't work. No recommendation means that we don't have enough data to say if it works or not. If something does not work, we have a recommendation that it doesn't work. For example, it was, I don't see it now, but low frequency RTMS to contralateral pain side is probably ineffective in neuropathic pain. So we have also some recommendation for something that we know that it doesn't work. As I said, no recommendation doesn't mean that it doesn't work. It wasn't enough studied. We have some recommendations for psychiatry, mostly. The first indication is depression. We are modulating the dorsolateral prefrontal cortex, as is written here, as the window to the depression network. The dorsolateral prefrontal cortex is very important in depression, but is not the most important area or the only area that is implied in depression. But through this window that we can access with TMS, we can modulate also the other regions. It was hypothesized that in depression, we have hyperactivity in the right DLPFC and hypoactivity in the left DLPFC. So with TMS, we can increase the activity of over the left DLPFC. I think I said wrong here. Increase over the left, or lower the activity in the right DLPFC, or we can do both. This was the first protocol that was ever approved by the FDA with the left DLPFC with 10 Hertz to increase the production of the neurotransmitters in that area. As you can see, the protocol was for 5 days a week for 6 weeks. Usually the protocols are like this for 5 days a week because we are lazy and we don't want to work in weekends, but this is how it works and this is the protocol and we must do it like this. Then after a while, we saw that we can do it in less time. It's not necessarily, we don't need 37 minutes. We can do it the same in 90 minutes just by reducing the time period between the stimulus. The stimulus is 4 seconds on, then there's a pause. 4 seconds of 10 Hertz stimulus, then a pause. As I said, we can do inhibitory over the right DLPFC. We have level B recommendation. Again, that it doesn't mean that it doesn't work as well as the excitatory of the left DLPFC, but it means that it's not as well studied. And as I said, we can do bilateral. We can do first the right DLPFC, then the left DLPFC. And it works. We have level B recommendation, but we have also a level C recommendation that it doesn't work better than any other treatment. So it's not that used, this treatment, because it's time consuming and it doesn't work better than the others, even if we do both. This is a newer type of treatment, the ITBS, the intermittent theta burst stimulation. We can do what we did in 37 minutes, we can do in 3 minutes. This is a study regarding the response rate from the first study versus the ITBS, and it's quite the same. This doesn't mean that it's the same. We can have patients that are responding, that are not responsive to a protocol, and they can be in remission after another protocol. In real life, there was a study for 12 months. In real life, the response rate and the remission rate is even better than in the studies. and the remission was at 12 months in up to 62% of the patients. I'll pass these. These are other studies individually regarding depression treatment. In OCD, we have a level C recommendation. That means a possible effect. As you can see in this study, there's a big difference versus sham. We have improvement in 45% of the patients who are using the real stimulation and 6% in those using the sham. So it's very effective, but there's not sufficient data to be any other than level C. In PTSD, we have level B. There was a study over 4 weeks. There were a lot of studies. I chose to show you this one. As you can see, in a week, they did stimulation over the right DLPFC, or first right, then left DLPFC. And as you can see, it works better for this case if we do both. It was an improvement in 62.5% of the patient. And very interestingly, in the sham section, it was 0 improvement. So very effective. We have possible efficacy of low frequency RTMS in auditory hallucination in schizophrenia. Also possible efficacy of high frequency RTMS over the left DLPFC in negative symptom of schizophrenia. If you want me to give you all the studies, I can share with you. No, there's no
but
problem.
I think there was a question this morning, very interesting question.
It's on chat.
Wait a second. What are the risks and benefits in using TMS to treat schizophrenia? It was a question for Tuomas, but it was appropriate for you because you know better the clinical aspects of TMS. So yeah, maybe you can address this. Maybe you can answer this question.
I can say something. Not a lot, because I personally do not treat schizophrenia. I'm a neurologist. The psychiatrist gives the indication to treat with TMS. I only do the protocol, but there are not a lot of side effects with TMS. It's very easy to do it, and it works. Try it. You can try it. If you feel that you're not controlling enough the patient with medication, it's worth to try it. I don't have any slide with the contraindications and the side effects, but I can tell you the side effects are very, very low. You can feel a mild discomfort over the skull in 0.0038% of the cases. So 3.8 per 100,000 stimulus, 3.8 in 100,000. You can have an epilepsy seizure during the treatment, but it's very important to know that it's one epileptic seizure. It doesn't mean that it gives you epilepsy. So this is the most serious side effect that you can have, but it's extremely low. I don't know anyone who knows anyone who suffered from an epilepsy crisis during TMS. So it worth try it. If Tuomas can share us some more, I'll leave it to him now or when he'll discuss whenever he wants.
I can comment quickly that I think it's nice that we answered more or less the same. So I also said that I again repeat that I'm definitely not an expert on clinical treatment of schizophrenic patients, but I've also understood that there's no specific adverse effects, specific for schizophrenic patients per se, and in general, like especially when you follow the safety guidelines of TMS, the risks in general are extremely low. So,
thank you. I'll go to craving. it was studied in TMS. It was studied in a lot of cravings and addictions, including alcohol craving, eating disorders, gambling disorders, methamphetamine, drug craving. For now, we have in the guidelines the recommendation only for cigarette craving, but again, it doesn't mean that it doesn't work also for the others. I know some colleagues from Milan that are using TMS for cocaine addiction, and they say it works incredibly well. I trust them, but it is not in the guideline, so it's not my promise for today. I only promise what's in the guideline. We can do it also for neuro rehabilitation and pain. As I said, I'm a neurologist. I like very much to use it. Transcranial and peripheral TMS for neuro rehabilitation and pain. For neuropathic pain, it was as level A efficacy also in 2014. So we know for sure that we have definite effect. It works very good for neuropathic pain. And I have a lot of patients with neuropathic pain as a neurologist. We speak about radiculopathies. We know someone who has some disc that is out of its place, and then a hand or a leg is numbed. This can work very, very good. Also for other types of neuropathic pains, for example, in post-herpetic or paraneoplastic in patients who have cancer, or in patients with cancer after chemo, they have neuropathic pain induced by the chemotherapy, and it works very good, and we can use it. There are some, I don't know, there's more of a myth with safety concerns regarding neoplastic patients with TENS, with transcutaneous electric stimulation. In TMS, we don't have these concerns. It works in fibromyalgia. Fibromyalgia is a disorder that is at the borderline of medical specialties, is at borderline. It might be a rheumatological disease, but it can have also implications in neurology, psychiatry. Fibromyalgia is very hard to explain, but the patient suffers a lot, and it's very hard to treat. Usually, we give antidepressives for fibromyalgia. Basically, you have pain all over your body, and if someone touches you, it bothers you a lot. And we have level B indication for fibromyalgia, probable effect of high frequency TMS in the left M1. M1 means primary motor cortex, in improving the quality of life in the patients with fibromyalgia, but also a probable effect of high frequency TMS over the left DLPFC, as in depression, for the analgesic effect in patients with fibromyalgia. CPRS, again, is very hard to imagine how this disease can happen. In this disease, you have, besides pain in one leg, one arm, besides that, member, that arm or leg, is usually swollen. It's hairless. It's very, very painful. In CPRS type 1, you don't see any injury in the nerve, but these patients suffer a lot from it. Usually it's after a stroke or a heart attack or some injury, but the pain is out of proportion to the severity of the initial injury. They suffer a lot from something, and you don't see anything wrong in there besides what you can see with your own eyes, that the trophic and the autonomic it's affected. As you can see here, we have 70% responders. For a short time, but also for a longer time in 51% of the patients, we have improvement. So we have it in our guidelines. Tinnitus, as I said at the beginning, is very, very hard to treat. This tinnitus, it has a high prevalence. Up to 20% of the population suffers from tinnitus. In 1 or 2% of the cases, it's very debilitating. I had patients who had a major depressive episode after tinnitus, and then depression. What's bothering is that in up to half of the cases, tinnitus remains idiopathic. As I say to my patients, idiopathic is a fancy word that doctors use to say that we don't know why it happened. And even worse than that, the medication is effective in 20% of the cases. What we can do for these patients, we can do TMS. TMS can help. As you can see, real TMS help 38% of the patients. It might not seem a lot, but for the patient, it's very much. And we can try it. In multiple sclerosis, it can work very well. We have a probable efficacy of intermittent theta burst stimulation. Again, in the primary cortex contralateral to the most affected limb to improve the lower limb spasticity. I have used it in 3 of my patients with limb spasticity. It worked very, very good. They want to do maintenance TMS. They're still fine, but they asked me when they can come to do another session just to be sure that they'll be this well for the next time. And I said that we shall see each other once in a month and to see how they're feeling. And if I see something wrong, we'll do maintenance TMS. But from my experience, it's working very, very good. In 2 of these patients, I did also peripheral TMS to lower the spasticity, and again, it worked perfectly fine. Intuitively, in epilepsy, as I said, if we use low-frequency TMS, we can lower the activity of that brain region. And intuitively, we can use it also in epilepsy to lower the activity of the regions that are hyper intense. I never used it in epilepsy, mostly because of extra precaution, because as I said, there's a very, very low chance to give the patient an epileptic crisis during the treatment. And if you already have epilepsy, it might be a bigger chance. In Alzheimer's disease, we can use it. Also, it works better in the stage of mild cognitive impairment. Now we are using multi-site stimulation. We can increase the activity in some regions that we want. We can decrease in some other regions, and it can work well. I personally did precuneous TMS in one patient with severe frontotemporal dementia, and it worked better than I thought. It was a patient with mini mental state examination 1 out of 30. Now the patient asks for some pajamas that she prefers, or asks for some food that she likes, and she goes by herself in the bed, and her husband is extremely delighted by this, and they're coming 200 kilometers twice a week just to do the TMS. We did first 10 sessions, but now there are 3 months, and they're still coming twice a week to do it. Again, studies for dementia and the improvement. I'll pass because I don't want to bore you too much. This is for Parkinson's. We can use bilateral stimulation of the primary motor cortex. The primary motor cortex is here. We can do it with a specific type of coil that covers both the primary areas once, and we can do also high frequency TMS to the left DLPFC in patients with Parkinson's and depression. As you can see, we have improvement in all of these studies of the UPDRS, the score of motor involvement in Parkinson's. In all of the studies were with the improvement. We have a level A efficacy in post-acute stroke. It doesn't matter if you're a student or someone from the street or it doesn't matter who you are. It's very important to recognize the stroke. And we have this mnemonic, FAST. F stands for face. You can see that the person is smiling asymmetrically. It's a drop on the side of the face. If you ask them to lift both their arms, you can see that one of the arms is lowering by itself, and the patients can have problems with speech. Can be this dysarthria or aphasia. They either they do not pronounce words very good, or they cannot say anything. And if you see this, call the emergency, because we have treatment, and time is brain. If you do it fast, the brain really will recover. Intuitively, you can say that we can do some excitatory stimulus over the brain where the stroke happened. And you are right if you think like that. We have here probable efficacy of the high frequency RTMS in the ipsilateral motor area in where the stroke happened. But surprisingly, it works better if we do low frequency RTMS to the normal side of the brain. So we can inhibit the hyperactivity in the normal side of the brain, and like that, the affected side recovers better than if we excite the region that was affected. It can work also for post-stroke aphasia, and it can work also for hemispatial neglect. I had one patient with hemispatial neglect. It worked very good for him from the first session, but then it wasn't maintained the beneficial effect.
How important is in hemispatial neglect treatment? How important it is to train that person in other cognitive recuperation? From your experience.
It's very hard to treat hemispatial neglect. We don't have something specifically designed for this. We can use VR glasses. This can help, but it's not a routine to use it. Usually, we advise the patients to cover the good eye and to use more the affected eye. But it's by itself, it doesn't improve that well. So it's good to have something in our toolbox to help these patients. If you don't do anything, after a while, they will not recover at all. You can use some glasses with some prisms to improve the vision, but there's nothing. There's no much thing that you can do after 6 months. So it's good to do something quickly in the post-acute stage. It's better to, in all sorts of recovery after stroke, it's as soon as you can start the recovery, it's good to do it. It's an interesting fact that RTMS works very, very good after stroke, together with how it's called, kinetotherapy. Let's say kinetotherapy. It works very good together with kinetotherapy, but it's interesting that you should do first the TMS, then the kinetotherapy. It works like this. If you do first the kinetotherapy, then the TMS, it doesn't work that fine, because the TMS prepares the brain to be trained during the kinetotherapy sessions, and they work very, very good in this order. As I said, this is not in our promise. This is not the promise of the TMS, but we are using this in our clinic with very good results, and the side effects are even lower than in the transcranial magnetic stimulation. We cannot have epileptic crisis, seizure in peripheral magnetic stimulation, and it's very comfortable to do it as a patient. It's very relaxing. It works almost similar to the TENS, to the transcutaneous electrical stimulation, but it's much more profound, and the TENS can be very bothering because it's that current that it's in your skin. This transcranial magnetic stimulation, it goes into the muscles, into the nerves, and it have a deeper effect and a faster effect. We can use it in myofascial pain syndrome. It was a study compared to TENS, and it worked much better than the TENS in the trapezius myofascial pain. In traumatic brachial plexopathy, it increased the hand grip strength. Also, there was improvement in electrophysiological parameters. In post-traumatic peripheral neuropathic pain, can work very good. As you can see, after the treatment in one study, sham controlled, a reduction of pain was in 60 up to 100% of the pain was. We had the reduction of up to 100% of the pain. It works in acute low back pain, and you can see it right away after the first session. Of course, if you do more session after that, the beneficial effect is for a longer time period. We can use it also in chronic low back pain with good results. As I said, in my patients with multiple sclerosis and spasticity, I do both transcranial and peripheral magnetic stimulation. They're working very good together. Here we have a picture with our TMS machine and how we can use it peripherally. You can increase the muscle strength. This is one study here with 15 sessions of peripheral magnetic stimulation. And it can help also patients with dysphagia. It's very important. And again, we don't have a lot of tools that we can use to help these patients. That was all. Thank you very much. I hope that it wasn't too technical or too much. And if you have questions, I'm here.
I'm having some questions.
Yeah.
Because I'm very curious about one thing. On MCI, for example, and also on depression. From your experience, I think you have a lot of experience.
Depression?
Yeah, in depression.
Okay.
And how important it is to do, let's say, a therapeutic session also.
It's very important. As I said, the TMS by itself, using TMS, only TMS, we can have a response in 50% of the cases and remission roughly 30% of the cases. If we use it together with psychotherapy or any other sort of therapy, you can have remission rates to up to 70%, and the remission rate stands for longer time periods than with TMS itself. So it's very, very important to do together with therapy. I didn't put it in the slides, but because it's not a promise, there are only studies, but it's very interesting. Our colleagues from Stanford, they did a study a few years ago. Yeah. Mm-hmm. And we saw after only 5 days of stimulus, 10 sessions per day, 90.38% of the cases they were positive, and up to 80%, if I remember well, 79 or 80% remission that lasted for a month. It's incredible.
Only by 5 sessions.
Only 5 days. 50
5
sessions.
days.
Yeah, 10 sessions per day. There are also accelerated protocols that we can use because we are lucky that we are in the European Union and we can do a lot of things here. In the United States, there are some regulations. Have you heard of FDA? And
yeah, we heard
they cannot do a lot of things. They must follow strictly the protocols. In the European Union, we can do a lot of things if we informed, of course, the patient that some of the indications, if they're off-label, we inform them. We can say, this is what we know. These are the risks. We don't know exactly what are the benefits if we do it. I showed them the studies, and if they agree, we can use it. In the accelerated, this is this protocol from Stanford. It's the type of accelerated protocol. As I remember, they were using also functional MRI to know that they are targeting the right region every time. But we can do accelerated protocols without fMRI. We can do maybe together with EEG. Maybe it's less expensive to do it like this, and it's very interesting. And I think that we'll do it in our clinic, EEG guided TMS in the next future.
Yeah, this is a subject also for Tuomas. Maybe
yeah, I know.
now and clear us a little bit about this issue. I have also some other I have a question because it was clear that if it is work on depression, it might work also on addiction. But for me, it's important to understand how does it actually go. It go on wanting, it go on liking, because addiction means also substance, means, as you said, cocaine. It's the craving that eliminates, or it's what? It's
usually, yes, we are targeting the craving.
Only the craving.
Yeah.
And the liking.
Because it's not in the guideline. I didn't use it. I've never used it, not even for a cocaine addiction, for a nicotine addiction. I didn't use the TMS. I have some patients that are interested. I think that I'll use it. We have efficacy that is well established, but our clinic, we're mostly concentrated on neurology and cardiology and less on psychiatry. I use TMS only in the patients that are referred by other psychiatrists from outside of our clinic.
Okay. Yeah, because it's very important to understand this. For the psychologist, it is very important to understand that there is less painful way to interact, to address the let's say addiction problem.
Yeah. Also for depression, usually all the studies were made in treatment-resistant patients because outside in the other parts of the world, not Romania, where it is not reimbursed, but in the other countries, TMS is usually reimbursed and it's for free for the patients. But it depends on the country.
What are the countries that you are referring to right now?
I was in Germany, and I was in a clinic, and they were using 5 TMS machines non-stop. And it was covered by both state and private insurance companies. But in a treatment-resistant depression, usually is you have to try first 2 treatments, 2 medical treatments. And if you're not responsive, the state or the private companies are paying for TMS because statistically, if you are using another medicine, the third one, the response rate is 70%, and the remission rate is 40%, 14%. It's very, very low. So it's worth to pay for TMS when where you have response in a half of the patients.
It's worth because
3 times.
Quality of the reading, it's increasing tremendously on patients with
we can use, of course, TMS in patients that are naive to treatment. We can use it also as a first-line treatment, but most of the studies are in patients with depression that is treatment resistant.
Okay.
And yes, ideally, it will be to use it together with therapy, because it works better and it works for a longer time period. And you can use therapy for maintenance.
Okay.
You can use also TMS for maintenance. Now I have a patient who did 30 sessions in France, and now he wants, and his psychiatrist told him to do it, to do first 2 sessions per week, and then he'll come once a week just for maintenance. In Germany, I saw some patients that were coming after 3 months or 6 months or after a year. I think I need some more TMS. 5 or more sessions. I think that I'd like some more TMS because I feel something, and I want to be good again.
Yeah. By the way, for this subject, you should follow our conference tomorrow morning because it's related to this subject about.
Yeah. Perfect.
Yeah. Thank you. How do I address myself?
Good.
What do I feel and what do I feel about the symptom? Is it real or not? Yes. I will get back to Tuomas because I think I interrupted him earlier with my question about addiction on MCI and recuperation.
Yeah, sorry. So can you repeat? Where did you interrupt me exactly?
About how TMS and EEG can work together on those kind of issues, on MCI, on depression, and
right. So so obviously this is at the moment it's on a very like a basic research level. But is it possible if I show just one slide to highlight like from the basic research like one problem with the problem that we have both at the research side and at the it might be also leaking into the clinical side as well. So because we heard from Dr. Pană very nicely about these different RTMS protocols and how they on average work or are thought to work. And but then the problem is that the individuals, they respond very differently. And this might also be causing that different studies have slightly different outcomes, whether it's a clinical study for depressive patients or whether it's a basic research. Because if you have a small sample, then you by kind of luck, you have a different subset of patients. So I just show you quick and dirty my slide. I think this is fine. It doesn't have to be in the presentation mode. But this is already like quite an old. I'm sure that Bogdan knows this study from. I think this is from Pascal Leon's group. But this is just to show like that on average we know that the we think that, for instance, like a low frequency stimulation of 1 Hz is inhibitive. That's like the rule of thumb, and then the high frequency stimulation is excitatory. And on the right hand side, this is already like 20 years old study, so we have known this for a long time. It is true that also here on average, the higher the frequency, the more the excitability increases. But actually, if we look at the individuals who make up these average responses, the responses can be highly variable. And this is just a basic study with the healthy subjects, but obviously the same event could be going on with the patients as well. Of course, with the patients, we don't necessarily do such a strong. You know, we don't read their EEG or we don't read their motor responses, but we just give them therapy, and for some of them it works, for some of them it doesn't work. And if, for instance, we take as for depression, the premise is that there is some sort of imbalance between the frontal cortices, and we want to balance that either by exciting the left protolateral prefrontal cortex or inhibiting the right one. Then, of course, if there are patients for whom the therapy works the other way around, then also we cannot maybe expect to have the results. So for this type of problems, the Aalto group and the group from Tübingen and the big EU project where I'm also collaborating and involved, the idea is that the EEG would be used for reading in the future, to read first of all read the individual brain states of the subject, to maybe individualize the treatment better for different patients, but also then possibly find like brain states or the moments of stimulation when it would be more efficient for this individual. And really, like, the idea would be to read the brain state from different areas of the cortex and target it in a more flexible way. This is kind of the I stop just in a second, but kind of this variability is one very big motivation for us for reading the EEG and try to individualize the treatment or research protocols. Also, the theta burst stimulation was mentioned. So on this figure, you can just see the variability in responses to in this theta burst stimulation. But yeah, that's basically the background. I think I interrupted some comment or question.
No, you didn't.
Ah, okay. I thought that I was hearing something.
No.
But yes, but that's basically the driving force. Of course, we know that the challenge at the moment is that, you know, we know that brain state affects the responsiveness. So if we have like extreme brain states, for instance, I showed earlier today the differences in the responsiveness when you're awake and when you're asleep. You can take these as two extreme differences in the brain state, and that clearly has like a drastic effect on the responsiveness. So we know that it is important, but then to identify from ongoing kind of poor quality EEG, raw EEG, to really to identify whether it's a frequency or a phase of a frequency, to identify the significant brain states, that's the challenge for the EEG-guided TMS. And so far we have seen, I think we have clear evidence that the EEG-guided TMS, it does work on average, but so far I would have to say, to be honest with you, that the effect size is very small. So again, there is variability between the subjects, even for the EEG-guided TMS, and on average the effect is small. So you need quite a bit of trials and subjects to get significant results, but the significance is there once you have enough data. That's the problem at the moment.
So the problem is this, the size of the research, the size of.
Yeah. I think we haven't. I'm a bit skeptical whether we have yet learned the correct way to read the brain states from EEG. Like, what would be the best way to diagnose the brain state in real time to target the TMS?
Can you develop a little bit here, because you got me curious in that.
So if I would have like a great solution, then of course I would have already promoted that. But I think at least one thing that we are using at the moment, I think ineffectively, is EEG, in the sense that the EEG gap, we have 60 channels or 120 channels, and actually the EEG, when the brain is active, the nature of EEG is such that the activity is everywhere in the scalp. So even if you have a focal source somewhere, actually if we look at the voltage patterns and the topographies, we get information from all the channels. So we are kind of from the tradition of EEG, how we use it currently, it's kind of a simplistic way where if we are interested in, let's say, motor area and we want to stimulate at high excitability states, we take EEG channels that are close by to the cortical region of interest. And I think that channel alone is a optimal window to that cortical region. But really, that is then kind of wasting a lot of information that we have, because if we could utilize all those 60 channels and some sort of physiological models of the brain, we could actually, I think there could be potential to go also in EEG a little bit more into like MRI guided EEG or anatomy guided EEG to try to read the brain states from certain kind of virtual channels that would be really like optimized for a cortical region of interest. Kind of in a similar way as we have now simplistic neuronavigation from TMS. We are not just targeting it on top of some 10-20 location or kind of rough location of DLPFC, at least not necessarily. We can have like MRI guided anatomy based location for the coil. And I think in a way something similar could be possible for EEG as well, because from MRI you can model what kind of signals in EEG in all the channels you would expect, for instance, from DLPFC. So I think that's at least something that where we could definitely improve. It's a different question whether it will be enough or whether we need some completely different ways to think about the brain activity.
Okay. Yeah.
I'm interested to hear what Bogdan, what's your take on this or comments?
Yeah, it's very interesting and very promising. In June this year, I was in Amsterdam to do the TMS course, and the team from Maastricht was also very interested in TMS in the EEG guided TMS. They think that this is the future for TMS. It's ideally it's very good to.
But why? Why this is the future? That's the question. Why do they think is the future?
Because up until now we don't have anything better. We don't know, as Tuomas told us, we don't know how we can see how the brain works, and we can do the TMS we can do the EEG to find out. And if we can see that with TMS by using TMS we see some activity in some particular brain region, then we know that we are stimulating the right area, and it will be more effective, the treatment. If we have also a feedback from the EEG, not only anatomically, we of course we are doing some measures of the brain, of the skull, to find out the DLPFC. This is called beam F3 method. Previously we were using some other methods, just measuring 5 or 7 centimeters from the motor hotspot. But now we think that it's better to measure each individual skull and to do it individually. But of course, it will be better to have a feedback, to know that we know for sure that we are stimulating the right region. And up until now, I think that the EEG can help us with this.
So that satisfies you, Tuomas, as the answer?
Yeah, well, I mean, I wasn't looking for. I was just interested genuinely to hear what Bogdan is saying. So I think Bogdan mentioned the neuronavigation. I think that is also something where, like the neuronavigation, it looks very fancy. And I mean, of course, it is tremendously helpful if you have done motor hotspot search, for instance, without neuronavigation, and then you have done it with the neuronavigation. Everybody knows that it's once you've tried both ways, you know that it's so much easier with the neuronavigation to have kind of a map. But actually, like those, many of them, from the technical point of view, some people might be actually surprised how simplistic many of the neuronavigation tools actually are. So there is a nice MRI-based anatomy, so you have kind of a map, but then there is like a dot on that cortical surface, showing you, kind of indicating for the user that this is the point that you are stimulating. But of course, if we look at the kind of a high-end modeling work that shows actually the distribution of the electric field of TMS, we know from this modeling work that, first of all, the electric field distribution, it is extremely complex how it's created. It depends on the conductivity of CSF. It depends on the conductivity of the gray matter, the shape of the brain. It depends on what is the exact orientation of the electric field locally to the anatomy. And of course, we know that the brain anatomy can be highly complex. So actually, the electric field is very complicated and it is subject specific. Now, this red dot that you might see on some commercial neuronavigation software indicating that this is the hotspot, it might, most of the time, it has nothing to do with the electric field. It's actually a projection of the scalp point, the center point of the coil that can be accurately measured by this stereotactic measurement, and then it's projected to the kind of normally to the cortical point. In the most advanced navigation software that are commercially available, it is the maximum of the electric field on a sphere that is kind of underneath this fancy 3D brain model. There is actually a locally fitted sphere that is fitted to the skull shape locally, and then the software underneath calculates the electric field on a sphere, and then it gives you the maximum of that electric field. But of course, in the research, we currently have already like tools, like the most advanced research work is computing in the realistic geometry the electric fields. And if I'm thinking, for instance, like a radiotherapy for some very complicated tumor removal, like for instance, you have a tumor in the throat, those have advanced very vastly over the 10 years or 15 years or so. And I think one reason is that they have like very advanced computational techniques nowadays to optimize the radiotherapy to the tumor and really avoid unnecessary radiation dose on the throat. So I wonder whether that could be one potential kind of place where we could really improve still TMS to really take the dosing onto a second, like a whole new level where we utilize the actual individual anatomy and really target the space that we think that we are targeting.
The specific, yeah, it's amazing. The future looks relatively bright for TMS and EEG in that matter. I don't know, Bogdan, how are you seeing? I mean, what do you think from your perspective as a clinician? What are your needs? If tomorrow you will have a magic baguette, what will you go after?
First, I want to thank Tuomas. It was very helpful for me because he reminded me about the neuronavigation and the TMS. I was interested in this a few years ago. It's very interesting. It seems like it can help us in the future. For now, it's a bit expensive to do it, and up until now, is not that much big of a difference of effectiveness, not even with neuronavigation. Maybe the future protocols will improve, and also with the help of some guided therapy like fMRI or EEG. We have the success story of, as I said, of our colleagues from Stanford. It's a very successful story to have complete remission in 80% of patients with major depressive disorder with suicidary ideation with who previously tried to suicide, and 80% remission in that case. All the protocols have improved a lot in the last years. That's why we have bought this machine, this therapy, 6 months ago. First, I wanted to be sure that as my presentation said, that it delivers what it promises. I was looking into buying one of these machines 4 years ago, and I waited until the protocols are good enough to deliver the promise, and we are there now. But there's a lot of things to be improved, of course.
Good. So as for this moment in clinical practice, and I don't know if Thomas researched a little bit on this, let's say, conjunction with other forms of, but I don't know if you research in clinical cases or something, but it was very interesting because I wanted to ask you, Bogdan, when you talked about therapy, is there a specific therapeutic method of therapeutic current that works better with TMS, or is just therapy in general?
As I know, and I'll come up to you later if something changes. Therapy in general.
So nothing specific.
Nothing specific. Yeah, the studies were made together with therapy. They didn't specify what kind of therapy.
Okay.
Yeah, it should worth to know because it might be important what kind of therapy, but we know for sure that it works much better together with therapy, the TMS.
So yeah, we forgot about our public. So guys, if there are questions in the Q&A section, please go ahead, ask everything you think you want to know, and also if our hosts are having questions, please address them directly. There is a question from Andra Bria. How efficient is TMS in stroke rehabilitation? It is safe to use it for a patient with epilepsy. If it is,
yeah. In after stroke, we have a level A grade of efficacy, so it's definite effect. As I said, it's good. It's better to do it quickly after the stroke in the post-acute stage. It works also in the chronic form, but it's better to do it in the post-acute stage. And it's good to do it together with kinetotherapy. And we are doing like this in our clinic with very good results. Nothing seriously happened with any of our patients so far. Nothing more than the slight discomfort during the sessions. So far, no safety concerns regarding patients with stroke. For the other question, in the epilepsy, we can use it. As I said, I've never used it because of extra precaution, and I don't have that many patients with epilepsy, but mainly for extra precaution because there's a very, very low chance to have epileptic seizure during the treatment. I see here also another question. If we use TMS in pediatric patients, if there are any contraindications. As I know, we can use it. There are a lot of studies for autism and other diseases, but our manufacturer, it's in our manual that it says that we cannot use it in pediatric population. You can use TMS, but in our clinic so far, up until the manufacturer will update the manual, we cannot use it. it's our manufacturer is one of the leading manufacturers in the world, probably the most studied, and they're very, very, very careful and extra precautious.
Yeah, that's good. You be precautious with your brain. So
can I comment, because there
please
was a Q&A question about epilepsy, and then there is a Q&A question about the pediatric patients, and EEG guided TMS. So so I just want to mention about this. As far as I've understood, like yeah, there are studies indeed with pediatric patients, but if you compare the literature of TMS as a whole, you know, as a therapeutic tool, as we saw at the first slides of Dr. Pană about like all the possible symptoms and diseases to which TMS has been tried, there is like the amount of pediatric studies is like very minuscule compared to the whole vast literature. But now there has been at least we have our department has now a collaboration with the Stanford University with Professor Fiona Palmer, and I think Corey Keller is involved with the idea of actually using TMS as a treatment tool for pediatric epileptic patients. So this is a very it has just started. It's very much basic research, but kind of the idea, the long-term goal could be to actually use real-time EEG to see when these spikes come, and use this EEG guided EEG to guide the TMS to the correct hotspot, the spike spot, to then inhibit those spikes and use that as a treatment tool. Also to couple in machine learning. So basically all the hot and cool spices that we currently have. Yeah, and it's a very fascinating line of research.
good. If we have questions from the host.
Yeah, so I was going to write in the chat, but I guess I'll just ask. It might be more of a basic question, but I wanted to ask, what is the rationale behind using different shapes for the coil? So you showed the circle and the H-shaped coil, and are there also other shapes being investigated?
Thank you. It's a good question. Yeah. First, we were using round-shaped coils. With a round-shaped coil, we can target a bigger brain area, maybe 10 square centimeters of brain area, with advantages and disadvantages. If we are using a round coil, it's a bigger chance to stimulate or to inhibit the region that we want. If we want a region of 3 square centimeters and we are using 10 square centimeters, it's a higher chance to stimulate it, but it's not that precise. It's not, we cannot do it in the right intensity, and it might be also a bit more not painful, but not as comfortable for the patient, because it will also stimulate some muscles around the face, and there will be some twitching during the examination. This happens also in the figure of 8 coil, but it's maybe it's more in the round-shaped coil. In the protocols, most of nowadays protocols are with figure of 8 shaped coil, because it's easier to do. Maybe it's easier, and it's more. It's better to do studies with figure of 8 shaped coil, because with that type of coil you can stimulate maybe 1 square centimeter of brain region, and if you do the correct angle and if you do it right, you can stimulate exactly the spot that you want. For Parkinson's, for example, we can use double shaped coils. They're all like this, and they can cover deeper areas. At the beginning I said that the coils are penetrating the skull and then to the brain at 2 or 3 centimeters. With this type of coil we can go maybe 3-4 centimeters, and there's also another shape of coil It's called an H-type coil. It's like a helmet that you put on your head. It can penetrate even deeper than the others. It's called deep TMS. The disadvantage of that coil is that it's like a helmet. It's quite big, quite expensive, and you can use it for only one target of the brain. Each helmet, it's for one region of the brain to stimulate. With the other coils, you can put it wherever you want. And of course, there are different sizes for both round and H-shaped coils, different sizes with advantages and disadvantages.
Okay.
Can I show a slide again from the future? So I think for this coil thing, I think I showed this slide earlier. Can you see the coils?
Yes.
So I want to just show what I do think that this will be. I mean, we already have like really good prototypes which actually work in this regard very well. I do think that this will be the future of TMS at some point. And here, I mean, yes. So there was a question whether there can be more coils, and indeed there are the 8 coils that were already mentioned, and that was a really good answer for the current kind of commercial coils that are very readily available for people. But I think this will be the technology that will come later on. So here you can see a schematic image of a figure of 8 coil, for instance, this A coil, and this would be the electric field that constructs. You can calculate it easily, but this is also the electric field that it produces in practice. And here is the same figure of 8 coil, basically just rotated 90 degrees. And this would be the spherical electric field. But you can also construct this kind of a figure of, what would this be? Kind of a combination of 2 figure of 8 coils and rotate that. And what we have constructed is a system of 5 coils. So all of these coils are stacked on top of each other. And the idea is that electronically you run current pulses through each of these coils at the same time, but with a little bit different combinations. And by running different combinations of pulses, you can actually mimic this figure of 8 coil electric field, but move it around. So in this square area, you can just kind of shift and rotate and shift this maximum electric field anywhere you want. And the whole electric field is not identical to this one. Like there is a little bit of, it is a little bit distorted on the sides, but really the electric field that affects is pretty similar here. And I think this will be the future, because we already have the technology in our lab where you electronically quite easily move the location, and that will just make life so much easier when you can, on the neuronavigation, you can basically click the point on the cortex that will be stimulated instead of having a operator moving the coil step by step. So I really think that, I don't know, in 10 years, 15 years, this will become more common.
Okay. Another question, are there researchers about TMS and cerebral palsy?
I don't remember exactly, but of course there are. It should be, they should be, but we don't know exactly so far what's the efficacy.
Okay.
But I saw that Tuomas has a lot of interesting slides in his presentations. He's giving us each one very he's very cheap. He doesn't give us all the information that he has.
Well, this was actually the morning session, so I just wanted to remind of the.
Sorry. I'm sorry, Tuomas.
No, I will provide you the presentation.
Yeah, for sure. I will share it, but I don't know how. It might not be that easy to follow without my speech, but for sure I will share the slides if you want.
No problem with that.
Yeah, thank you very much.
Tuomas, do you know something about TMS and cerebral palsy?
No, I have to admit that in this I'm I'm ignorant.
Okay, no, I mean, okay. Some other questions from the hosts do we have?
There is one more question in the chat. So someone is asking about using TMS for dyslexia, and they mentioned that it works to treat dyslexic patients with TDCS, but they would also like to know about TMS in this case.
I know for sure that it works in aphasia, but it's completely different type of speech disorder. I don't know. I don't know exactly if it works in dyslexia. For sure, we can find out. If you tell me who asked, I can search.
I think it's Simone Cascone. I will, if you can provide the result of the research to me, I'll make sure that he's
perfect. He mentioned the TDCS. If TDCS was studied in dyslexia, most probably RTMS was studied too, because TDCS started sooner. It's more recent. It's not for now. It's not as well studied as RTMS. So most probably we have some studies also with RTMS.
Okay. Another question is: are there protocols in place to treat different diseases? I confess that I don't really understand the question, but here you go. You can answer if you want.
Well, I mean, we already heard that. I think we already heard, like examples of different protocols that can be used. Yeah. So, I mean, the classic classic parameters that are typically varied are the frequency of the stimulation. Of course, the protocol can consist of, I'm kind of now stealing this. I'm kind of repeating what Bogdan already saw, but you saw that there can be different schedules for the treatment, how long the treatment lasts. Obviously, the stimulation location can depend on the disease or syndrome. Like obviously, if you have a stroke and you have movement disabilities, you are targeting different regions than for instance, depression. So these type of variations for sure. Also for in addition to the protocols that we already heard of, did you Bogdan mention the PAS protocols? I can't remember if you mentioned PAS. And so that's at least one kind of PAS, the paired associate stimulation. So that's at least one on a clinical research level, like a promising protocol where in stroke patients, you can stimulate the, for instance, cortex with the TMS, and then you can have electric stimulation of the limb. And the idea is that those signals will then collide and improve synaptic connections between. So that's another like an interesting protocol that is slightly different from the RTMS protocol.
Yes, we are doing this, not exactly what you said, but we are doing this in our clinic. TMS together with kinetotherapy, but also TENS, and also peripheral nerve stimulation with the same machine as the TMS. We are stimulating the nerves with the same coil that we are stimulating the brain. And this is the rationale to stimulate the nerves both ways, anterograde and retrograde, and it works better like this. Yeah.
If there are questions from the hosts.
So I have a question regarding TMS for migraines. Would this affect the intensity, the frequency? Would it affect both? And would we expect to see a change in the aura phase?
RTMS in migraine, you said?
Mm-hmm.
Yeah. Okay. Migraine is my favorite disease.
Okay.
I like very much migraine. In migraine, the most studied type of TMS is a portable one. It's called single pulse TMS. It's very small. You can use it in your home office or wherever you want. It works very good. It's FDA approved. It's a machine, and with the help of this machine, you can disrupt the aura phase of the migraine. The aura phase of the migraine, it's a little bit like an epileptic crisis, like an epileptic seizure. And with this inhibition, you can stop it. You can stop the aura. The aura phase of the migraine is from 5 minutes to 1 hour, so you have enough time to take your machine and put it in the back of your skull and use it. And you can stop the aura and stop the migraine after the aura. And it's very easy to use with little to no side effects. But it's a different machine that the RTMS that we are talking today. In 2014, it was in the guidelines, also the migraine, but it was with a recommendation of no recommendation. Again, it doesn't mean that it doesn't work, but we hadn't enough data in 2014 to give that recommendation. There are very promising studies nowadays. First, there were studies in migraine with high frequency over the left PFC. They might not work as well as we have expected. Now, there are studies with that are targeting multiple areas of the brain with high frequency. I saw 2 studies from last year. They're working very good. I have used them in 2 patients, but because they're not in the guidelines so far, for sure it will be a protocol also in the guidelines for migraine and headaches. But because they're not in the guidelines so far, I have used TMS in migraines with comorbid depression. So I knew that for sure my patient will benefit from the TMS.
Okay, and the last question for Tuomas, because he's, and I request surely a brief answer. We have tomorrow a panel in artificial intelligence and how artificial intelligence is going to interact with neuroscience. But I would just want to know from your point of view how artificial intelligence will interact with TMS and with real-time analysis of brain activity.
Thank you. Very nice, fascinating question. I do see that there's a lot of potential. I think that could be one solution that could save us from a lot of troubles. When I told you that the EEG guided TMS could be one potential solution to decrease the variability between the subjects and try to find those optimal brain states. But at the same time, I told you that I'm not very well aware like what are those optimal brain states. So that's actually one very vital part of the current like EU project that we have is to develop also algorithms for this real-time EEG and try to utilize machine learning to find those brain states. So it might be that in the end, we don't necessarily have to guess them or know them in advance by ourselves from a priori information. If we collect enough data and we can fully utilize this multidimensional EEG data, maybe the machine learning algorithms could find us those optimal states to either increase or decrease the excitability of the cortex. And that already would be like a huge finding also for many clinical applications, if we could find optimal points to either increase or decrease the activity.
Good, thank you for the answer. Thank you for participating at this panel discussion. I hope that next year we're going to see each other in person here at Bucharest. It's going to be very interesting. Thank you, Bogdan. Thank you, Tuomas.
Thank you very much.
Let's
Thank
see
you
each
very
other
much.
next time.